Oh, no. I'm actually an educator. I teach for NEET PG entrance.
Like dams or what?
Cerebellum is the name of the app on which I teach. It's like
Okay.
DAMS only, but it is an online app. It's not an offline app.
It's online is good, yeah, right?
Yes,
Because
yes.
dams you have to go to Sholapur and here and there.
Uh, so this is easier for the students.
Yeah, it's easier for students.
Mhm.
And you are you related to Nikhil Nasta?
Yeah, he's my cousin. He's from my mother's side, but we are coincidentally both Nastas only.
Because he's a very close friend of mine.
Acha.
Nikhil.
Yeah,
He's doing pretty well.
yeah.
Do you meet him or you don't?
Not that much. Only on social events. Otherwise,
Yeah.
no.
He's ophthalmologist to Arnab Goswami. Big person.
Yeah.
So you teach every day or weekends?
No, no, it is variable. Whenever they want me to be teaching, I have to teach. That's not fixed.
Okay. I think we should start, right? It's
Yeah,
9:05. Are we
yeah.
waiting for Sir? Priya? Is Priya there? Dr. Siddharth?
Ma'am, I'm here, ma'am.
Okay.
Hello.
Yeah,
Madam, I
Priya.
think sir, both of them are not available right now, so we can start anyway.
Chalega. Let's get
No?
started.
Yeah.
I
We
think
can
Dr.
start.
Amrit has already introduced himself, so we can start.
Okay.
So Dr. Siddharth is second year DNB resident from Sargangaram Hospital at Delhi. So he'll be presenting today's case.
Go for it, Dr. Siddharth.
Good evening, everyone. I'll be presenting a case of a lady, 39 years of age, resident of Bharatpur, Rajasthan, homemaker by occupation, lower middle socio-economic status. She presented to us with chief complaints of lump in right breast for 5 months. Patient was apparently well 5 months back when she felt a lump in the outer aspect of right breast, which was insidious in onset, initially small, and has gradually increased in size to its current size. Not associated with pain or fever, not associated with ulceration or skin changes over the breast, not associated with any nipple changes, no history of trauma, no history of recent unintentional weight loss or reduced appetite, no history of jaundice, no history of cough or chest pain, difficulty in breathing, no history of headache or back pain, no history of swelling in opposite breast or same side axilla noted by the patient. Past history, no history of any breast swelling in the past, no history of any major medical illness, no history of any comorbidities, no history of any radiation exposure, no history of use of any hormonal therapies like oral contraceptive pills. Personal history, she takes vegetarian diet, normal appetite, takes adequate sleep. There is no change in bowel, bladder habits or sleep habits, no history of any substance abuse. Menstrual and obstetric history, menarche at 14 years of age, regular cycles, normal flow, married at the age of 22 years, two children, first life birth at 23 years of age. Both were full term, normal vaginal delivery. Both children were breastfed for 1 year each, cumulative 2 years. Summary. Lady, 39 years of age, non-smoker, non-alcoholic with no comorbidities, presented with painless, gradually progressing lump in outer aspect of right breast for 5 months, not associated with ulceration, nipple discharge, swelling in contralateral breast, with no history of any malignancy in the family.
Dr. Radha, you want to start with the questioning, or if you're okay, I will ask some questions.
No, you start. You start. You start. Dr. Nasta, please continue.
Thank you. Dr. Siddharth, can we go to demography? Your history is over, right?
Yes, yes, sir.
So
That's
I'll
only
just
okay.
ask a basic question. What are the components of demography when we take a long case? What all should be included in demography?
Um, sir, age, gender, and residential residence of the patient, occupation, and socioeconomic status, sir.
What is the relevance of age in a breast case?
Sir, depending on the age, in lower age group, like between 20 to 30 years of age, benign diseases are most common,
Like,
and malignancy, like fibroadenoma, sir.
and in what age group do you normally get fibroadenoma?
Uh, Between the puberty and post-puberty till the age of 30, 25, 30, sir, more commonly, sir.
Okay, normally 15 to 25. ठीक है. And what age do you get malignancy? Normally.
Sir, more common after the age of 35, predominantly between 40 to 50 years of age, sir.
Okay, normally after 50 or 60 years of age. If a young woman gets a malignancy, like she's 30 years or 39 is also fairly young, then what would you think? Why should a young patient get malignancy?
It must be there must be some family history or genetic component involved, sir.
Like,
Or um, uh, there may be any genetic mutation like BRCA mutation, sir, which
okay.
predisposes the patient to
And
malignancy, sir.
why did you ask about socioeconomic status? Does it have any bearing? Or it's just a
Sir,
part of demography?
no, the socioeconomic status makes us take a informed decision with the patient regarding the treatment, sir.
In
Patient
context
may
of
be
breast cancer, is there any relevance of
The
socioeconomic?
relevance of the socioeconomic in breast cancer. Forget the treatment part.
Yeah. Any
sir,
relevance in breast
breast
cancer?
cancer. Yes, sir. Breast cancer is more commonly seen in higher socioeconomic status.
Why is that?
Any community,
In general population.
any specific community you see this?
More commonly, according to the textbooks, ma'am, according to like Caucasians, ma'am, white.
Especially the Indian community I'm talking about. Please not talking about India, in India.
No, ma'am, sorry.
Once upon a time, you used to say Parsi and Punjabis. I don't know what it is now. Dr. Nasta would know, right?
No, now it is evenly distributed, but yeah, earlier there was some preponderance, but now it is evenly distributed. And yes, you're right, it is more common in higher socioeconomic status. What is the reason for that?
Sir, because the generalized trend of increase in body weight throughout the population in the world, along with the
Any other?
more incidence of obesity and socioeconomic factors like
Any other?
alcohol,
Right.
social factors like alcohol intake or abuse of tobacco.
So some of the
Any
risk
form.
factors like obesity and alcohol consumption, which are risk factors for breast cancer, earlier were more common in patients of higher socioeconomic status, but now they are seen in lower socioeconomic strata also. That is fine. Okay, we can move to the next slide.
I wanted to ask something here now.
Yeah.
Can I ask Dr. Nasta?
Yes, please,
Okay,
please.
you said about the family history, right? So, what is the difference between hereditary and familial?
Ma'am, familial is without when the patient has family history of malignancies in the family, but there is no associated syndromic involvement. But in hereditary like disorders, there is any syndromic involvement or a known genetic mutation.
Okay. Can you elaborate on a hereditary family
Ma'am, in
history? Talk about the family history, huh? Which
yes, ma'am.
malignancies are associated with CA breast in the family? What would you ask for?
There may be association with hereditary syndromes like Leigh-Fromeny or Cowden syndrome, ma'am, or which if these are present, then there might be any TP53 mutation or a CDK, ma'am.
So that's quite rare. What about BRCA1, BRCA2 related cancer?
BRCA, yes, ma'am. Yes, sir. BRCA1,
What other
BRCA2 as
cancers
well.
are seen in BRCA1 and BRCA2?
BRCA cancers. Tell me about the BRCA cancers in the family. Tell me what type of cancers will come in this.
Ma'am, in females, like patient ovarian cancer, ma'am, and along with that pancreatic malignancies. But if it
Good.
was a male patient, then prostate malignancy also, ma'am.
Colonic.
Colonic, not so common, ma'am, with BRCA mutation.
Okay.
Uh, It-
What are the high risk factors for malignancy which are familial? CA
Uh,
breast, familial.
see, BRCA1 and BRCA2, along with TP53, are among the top three, ma'am. But TP53 being rare is not commonly seen, but the penetrance and the percentage is higher in these patients. Along with that, there could be even Puig syndrome, ma'am, with uh, STK11 mutation or Cowden syndrome, ma'am.
What do you mean by first degree relatives?
Degree relative when there is no
Include
generational gap, there is no generational gap, mother, sister, father, or brother, ma'am, first generation directly.
children. Okay, fine.
Children, yes, ma'am, children.
Siddharth,
So
if a
carry on.
patient is BRCA1 positive, like she had family history and she got gene tested and BRCA1 was positive, what are the chances that she will get breast cancer in her life with
Uh,
BRCA1 and BRCA2?
with,
Like, is there a guarantee that this mutation will lead to breast cancer in the patient if it is there?
no, no, sir. It is not 100%, sir. Approximately 50 to 60%, sir.
For
Uh,
both?
Is there a scoring? Is there a scoring?
more. Yes, ma'am. 50 to 60% more in BRCA1 mutation compared to BRCA2, sir. And there are scoring systems, ma'am. Like like there are risk assessment tools like BRCA Pro scoring system where we actually assess the patient for risk of BRCA mutation.
When do you start for the screening and when do you start the investigation if they're high risk BRCA?
If the
At
patient
what age?
is a known case for BRCA mutation, ma'am, then then we start screening the patient at the age of 25, ma'am. Um, uh,
We
and
start
we
investigation at 25 or we start screening at 25.
screening at 25, ma'am.
Is that so, Dr. Nasta? Because I thought it's much earlier, 18
It,
screening
it,
and
18 to 21, you start with clinical breast examination,
yeah,
cell breast
exactly. That's what I
examination and
thought.
clinical. Imaging is done from the age of 25.
Exactly. That's what I thought, right? Okay,
Uh,
carry on, sir.
uh, yes.
Carry on, carry on. Where do we go now?
Okay, so you're on chief complaint and you said your patient has a breast lump for 5 months. Can you give me some differentials for a patient who's 39-year-old and what breast lumps are possible apart from breast cancer?
Uh, because the progression has been fairly faster than I would put differential like Phyllodes tumor a little higher up, or also fibroadenoma because the patient is of younger age group.
Okay.
Along with this, mm,
Any other?
there can also be mm,
What are the other differentials? Your two differentials are ductal cancer, phyllides, and maybe fibroadenoma. Can it be anything else?
papilloma, sir, but not very
Pa-
common.
Papillomas don't present with
Not
lump.
much big.
They present with
Yes,
nipple discharge. Any
nipple
other?
discharge. Yes,
What
sir.
what about fibrocystic disease? Is it common or is it uncommon? What?
Yes, sir. Yes, ma'am. Common, ma'am, but patient does not have associated pain, so it does not reach my differential.
Pain तो subjective चीज है यार, means I just asked for differentials. So fibrocystic disease can be one. It can be she had a breast abscess for some reason and it developed into an antibioma. Could be granulomatous mastitis. So there are 4 or 5
Granule
different
making
that should be there at the back of your mind. So
as
now we
listening,
go
sir.
to your negative history. Can you tell me the components of negative history when we take any case? After your ODP is done, like you're asking for pain, fever, ulceration, and all, like what all things do you keep in your mind when you're taking negative history?
So negative history when there are any associated factors related to the lump. If
Right.
there was pain or fever, it could make us lead towards diagnosis of abscess or fibrocystic disease or
Okay.
nipple discharge, nipple retraction pertaining to the disease itself. And along with that, if there are any systemic manifestations of the disease or metastatic manifestations of the disease, if we are considering a malignancy, sir.
What
What
else?
type of nipple discharge do you get in malignancy? What are the three S's?
Um, Ma'am, serous discharge, ma'am, is more common, but there can be bloody discharge as well. Uh, these are
What
the
are the
two
three
types of
S stands for? Three S. Spontaneous,
serious.
serious, and what is the one more S?
So
I don't know.
solitary or single duct means coming from one side.
Single duct. Single duct.
Okay.
Okay. What is when do you get ulceration in the nipple areolar complex? Which malignancy?
Mhm. Ma'am, Paget's disease of nipple, ma'am,
Can you
where there
define
is
Paget's disease? Can you give a proper definition of Paget's disease, please?
Paget's disease is a um, malignancy involving the nipple areola complex, predominantly with or without any lump present underneath in the breast.
It's a superficial manifestation of a deeper seated carcinoma. That's Paget's disease. Okay, carry on. Why do you get nipple retraction in malignancy?
Nipple retraction because the malignancy itself infiltrates into the ducts which are involved, lactiferous ducts, and this causes contraction and leading to nipple retraction.
Is
What
there
do
any
you ask whenever there is a nipple retraction? What is the other two histories you ask?
If this is present before the onset of lump, then it must be
Whether it is recent or it has been there for some time, right?
yes,
So
sir. Yes, sir.
recent see, okay, carry on.
is there any
So
benign condition where you'll get nipple retraction? Or it's only seen in malignancies infiltrating lactiferous ducts?
No, sir, there can be congenital nipple retraction present in the
What is
patient.
that called?
But,
Congenital nipple retraction. It's not called retraction. And how do you differentiate congenital nipple retraction? It's actually called nipple inversion. Some people have inverted nipples. How do you differentiate it from pathological retraction?
Sir, we try to compress the areola from all the sides, and if the nipple is everted spontaneously, then it is more likely to be congenital.
Okay. Acha, chalo, it's not spontaneous, but theek hai. Usually inversion is bilateral if it is physiological. It is bilateral and it is reversible. And obviously retraction is pathological, it will be irreversible. Is there any benign condition which will cause nipple retraction? Not inversion, retraction. Any benign condition which also
Mhm.
presents with nipple discharge and not with a lump.
Ductectasia,
Yes.
ductectasia,
So you can get
ductectasia.
nipple retraction in ductectasia because that also
what is the
infiltrates
definition
the
of
duct.
ductectasia? Dr. Siddharth, what is ductectasia?
Ma'am, when there is like the name itself suggests it, ma'am, when there is an ectatic duct with an abnormal inflammation leading to greenish nipple discharge, ma'am. That's ductectasia.
What is the treatment of ductectasia? It's a dilatation of duct. But what is the treatment of ductectasia?
Ma'am, there's a procedure named Hatfield's procedure, ma'am, where we excise the duct which is involved in ductectasia, ma'am.
Can't we treat it conservatively?
Mhm. Yes, ma'am, but it is because it has significant nipple discharge and also it increases risk of disease progression into malignancy in some cases, and that's why we go for the procedure, ma'am.
Is it a pre-malignant condition? I don't know. Dr. Nasa, it's a pre-malignant condition, ductectasia.
No, it's not.
I
It
don't
can
know.
lead to mammary
We'll
fistula.
look at the pathway, ma'am.
Yeah.
Ma'am,
Okay.
What are the
no.
skin changes you're talking about over the breast?
Uh, Ma'am, skin changes like ulceration, ma'am, or there might be any multicentric disease or satellite nodules, ma'am, which are present over the breast, which can cause the skin changes. There can also be dimpling or retraction, dimpling of the skin, puckering of the skin, ma'am.
Dimpling.
Yes, ma'am.
Dimpling of the skin.
Yes,
What is
ma'am.
photo orange?
Yes, ma'am. Powder orange can also be present, ma'am. It is
What is photo orange?
generalized edema. It is edema over the breast, ma'am, which is caused due to subdermal blockage of lymphatics, ma'am.
Why does it look like an orange peel if there is just edema? Normally, when we get edema in the legs and all, it does not look like an orange. Why does it look like an orange in the breast?
There's something else along with it. Something which gives it a peel appearance, that depression in between. Depression with edema. Depression with edema. Why? What is that depression there?
I think it's because of the subdermal blockage of lymphatics, ma'am. That's the only thing, and that
Yeah.
causes because of the spherical nature of the
It's
liver.
because of the infiltration of the lymphatics, right? Plus with what? Why do you get a pitting in between? Edema, pitting. It's like an orange peel. Why? That's what sir is asking.
I don't know, ma'am. Sorry.
It's because the hair follicles stand out on the
Follicle.
breast.
Why do you get
Okay.
retraction of the nipple? Did we ask this question?
Yeah,
Why do you
yeah,
get
we asked.
Okay. Now coming, is it a direct infiltration of the cutaneous lymphatics, or it is indirect infiltration of the cutaneous lymphatics in case of malignancy?
Direct infiltration, ma'am. Direct
No, it's
infiltration
not.
because of the.
It's indirect. Can we get Poda orange in a non-malignant breast?
Yes, ma'am, but it is like it is more specific for
Yeah, but can we
malignancy.
get it in non-malignancy?
Yes, ma'am. Yes, ma'am. Yes, ma'am. Yes.
In this condition, where can we get it?
Breast
Poda
abscess
orange?
also, ma'am. Breast
Yeah,
abscess
okay.
also. Yes.
Fine. Let's take it. So, continue, sir.
Next slide. So why did you ask for trauma?
In some cases, ma'am, there might be a trauma to the breast before the appearance of the lump. The trauma may not be the cause for the lump itself, but it may suggest that the lump might have been there and the patient must have seen it after the trauma incident.
So you're
But
asking trauma only incidentally.
it could be, sir, but it can also cause fat necrosis, which can also form a lump.
So that was one of the differentials of the breast lump in your patient. Means it's not necessarily malignant. One of the differentials was traumatic fat necrosis. Why jaundice and abdominal distension?
Sir, if these are metastatic features of if there are any metastatic features, I want to rule them out here itself, in the history, and that's the reason I've asked.
Metastasis to what? Metastasis to
Metastatic
what?
to liver, metastasis to livers,
Okay.
liver.
So, how does it spread to liver? What are the
Hematogenous spread,
modes?
ma'am.
Pardon?
Hematogenous spread, ma'am. To the liver.
And
Mhm.
only hematogenous?
Right, yes, that's what I don't know.
You don't know. Okay. Translomic. Okay,
Transcelomic.
fine.
Does liver mets lead to jaundice?
Not so commonly, sir, but if it was an advanced stage disease, then it would have caused.
Means patient should be having cirrhosis and metastasis, then maybe. How does a cancer which spread to liver cause jaundice? Is it really possible?
No, sir. Like most commonly, it does not. Like when there is infiltration into the liver, it is most commonly asymptomatic.
Yeah.
But there could be some hepatomegaly, which may be prominent on systemic examination. But in
ठीक है, चलो
yes,
जाने दो. Let that be. You're on hematogenous metastasis. Where does breast cancer most commonly metastasize?
to lungs, sir, most commonly lungs
No,
and bones.
no, it is lumbar vertebra. Bones,
Lumbar
but
vertebra.
lumbar vertebra. So, see, what I'm trying to say is this negative history is not going in any order. When we go to negative history, it has three prongs. That's what I asked you originally. The first prong is associated symptoms, which you said correctly. The second prong is etiology. Now, in etiology, you could have ruled out malignancy, which you have in a way. Then you could have ruled out other differentials like fibroadenoma or traumatic fat necrosis or granulomatous mastitis. Phyllides you can't really rule out on history. Then you go to complications, and in complications for cancer, it is metastasis. So there you can ask for ulceration, fungation, the hematogenous metastatic features that you asked, like back pain, jaundice, distension. What is the last line? History of swelling in opposite breast or axilla?
There may be synchronous lesions in the opposite breast or axilla that the
Can
patient must have.
can breast cancer of the right go to the left breast? Can cancer spread from one breast to the other?
There
Or
are
it is,
there are synchro
or it will be what you are saying, synchronous lesions, means two different cancers.
two distinct cancers most commonly, sir, but it can spread, sir. Like it
How?
spreads into the
How?
not into the breast, sir, but into the lymph nodes, sir, opposite side.
Nee. I am only
Metastatic.
asking, can I get right breast cancer spreading to left breast?
No,
No, it's not
no,
possible.
no, no,
So
no.
if I have lumps in both breasts, they will be synchronous cancers,
Yes, sir.
means double primary.
Um, yes, sir. Like at the same time, the patient must be having double primary.
Okay. Nor in which patients are likely to have double primaries?
Patients with high risk factors like BRCA mutations, older
Yeah.
age patients,
Yeah. So
hormonal.
normally BRCA mutants are the
Which
patients who will get.
histopathological, which histopathological cancer is bilateral?
Sorry, ma'am, I could not hear it, ma'am.
Which histopathological cancers are bilateral?
Mm, Ma'am, triple negative breast cancers are most commonly bilateral.
No. Lobular?
Lobular, yes, lobular, yes,
Invasive lobular.
Okay.
invasive lobular, yes.
Can I can I can a right breast cancer go to left axilla?
Yes, sir, that can happen, sir.
How?
Uh, lymphatogenous spreads sometimes
How? But
can
right
occur,
breast
or
should go to
hematogenous.
right breast will go to right axilla, lymphatic. How can it go to left axilla?
Uh, it can spread as a distant metastasis. It is not called locoregional like
नहीं,
lymphatic spread.
but डिस्टेंट में
It is
कैसे
not.
होगा? राइट ब्रेस्ट का कोई कनेक्शन है लेफ्ट एक्सिला से या लेफ्ट नेक
Mm,
नोड से?
No, sir, but it can spread through the hematogenous route or through the.
Hematogenous, so it will go to hematogenous organs. How will it go to lymphatic organs hematogenously?
Right, it's true, sir, but how I don't.
It is possible. There are 4 or 5 pathways. They are not very common, but there are 4 or 5 pathways by which right breast can involve left-sided lymphatics. One pathway which I know is it can go from right breast to right internal mammary to left internal mammary to left axilla or to the left neck nodes. In Bailey, there is a blue box which shows all the different pathways. I don't remember, but this is one of them. But it is possible, but it is not, as you correctly said, loco-regional. It will be counted as M1 disease. You don't call it as N, it will be counted as M1 only. ठीक है आगे let's go to the next slide. What are the risk
How
factors?
does it go to lumbar vertebra?
Through
Metastasis?
the through the Bateson's plexus, ma'am, through the venous
Hello,
drainage.
Siddharth?
Yes, ma'am. Can you hear me, ma'am?
Yeah, okay. Yeah, proceed.
Yes, ma'am.
Proceed.
Through the Bateson's
Hello.
plexus, ma'am. Hello, can you
Yeah,
hear me,
okay,
ma'am?
proceed. No
Tell me,
history of any swelling in the past. Okay.
tell me
I
the
can hear
medical and
you.
obstetric risk factors for breast cancer, which I think is there in the next slide.
Yes, sir. Yes, sir. If there was early menarche,
What is
late,
early menarche?
uh, um, less than 13 years of age, sir.
Less than 12 years. Okay.
Okay. Okay.
What is late menopause?
Uh, After more than 55 years of age, sir.
Correct. What other risk factors are there?
Nulliparity, if there was, or and um, uh, first childbirth before the age of 18 can be protective, sir, and breastfeeding for more than 1 year, more than 2 years cumulative is um, a protective factor.
No, no. One year cumulative, we have given for this particular case as cumulative 2 years, right? So it's 1 year or 2 years breastfeeding.
2 years, sir. 2 years, ma'am. Cumulative more than
In
2 is
general, Siddharth, not like that. In general, Dr. Siddharth.
In general, 1 year, ma'am, but in our patient it is 2 years.
Is
So it is
okay.
more
Is abortion
protective.
a risk factor for malignancy? Is it known?
Mm, no, ma'am. No.
Okay,
You
fine.
said if she's having
Can we proceed or we have to?
if you're saying that the first child was born before 18, which is not very common, then it is protective. So is there a opposite of this, late age of first child birth, which is detrimental?
Yes. More than 30 years of age, sir.
More than
If the
35
child,
years. After first child after 35 is negative, means it will have a detrimental effect. What is the role of OC pills and breast cancer?
Yeah,
uh,
exactly.
yes, sir. Initially, it was thought that it is possible. Then it is debunked. But it has been found that E plus P, estrogen and progesterone replacement therapies are more like harmful compared to estrogen only, and they can confer or like risk for malignancy, breast cancer.
To put it simply, OC pills in today's day and age have a negligible risk. The relative risk is not even 1.1. That's a number given in Bailey. So the risk is negligible. You can safely take OC pills, but HRT confers a much higher risk, hormone replacement therapy. That confers a much higher
Yeah,
risk because of the
I was
estrogen.
just going to ask him about that.
Yeah.
Right.
ठीक है. You can go to the next
We
slide.
can proceed now.
Yeah.
Summary, okay,
General.
fine. Physical exam. Okay, start the examination.
Yeah. Coming to the general physical examination, patient was
Yeah, carry
examined
on,
with
Siddharth.
patient was examined with adequate privacy after taking informed verbal consent in presence of a female chaperone. Moderately built and well nourished, calm, conscious, cooperative, well oriented to time, place, and person. ECOG performance status 0, BMI 22.4. Vitals vitals are
What
are
is
fairly
the
normal.
meaning of? Okay, can we go back? Can we go back? Siddharth, can we go back? Well
Yes,
built.
sir.
What do you mean by well built? What is built? Built
Um,
is
built-in nourishment is on the basis of patient's BMI, ma'am, along with the hydration status and
what is
um,
no? What does built mean? What is built?
built is um,
It's
built
skeletal
is
makeup.
It is a
skeletal.
skeletal
Yes,
framework.
Skeletal.
yes.
Okay.
Yes.
Next slide. Fine. Calm, conscious, well oriented. In which condition she won't be well oriented?
Uh, patient, I'm expecting her to be well oriented because of her performance status and general history, as she's explaining, ma'am. But she won't be well oriented if the patient was like non-coherent or not in an emergency state, ma'am,
Ma'am is
which
asking
she is not.
connection of breast cancer and loss of orientation. Means why will
Yeah,
she be
that's
disoriented?
yeah.
Breast cancer may can she be disoriented?
Unlikely, sir.
Why?
But
Metastatic?
metastasis may be possible. May be possible, ma'am.
Why?
Yes.
Why it is liver
Metastasis.
involvement? Can't she have liver failure?
Yes, sir. Yes, sir. Yes.
Or brain
Okay, next
metastasis.
slide.
Easiest. Brain
Brain
metastasis
metastasis.
raised ICD. ठीक है. Next slide.
Vitals are fairly normal. Local examination. Patient was exposed up till the waist and was examined in different positions, sitting with arms by the side of the body, raised above the body, semi-recumbent position, recumbent position, and leaning forward position. Sitting position with arms by the side. Inspection. Both the breast and nipples were seen at the seam level with no puckering or dimpling. Swelling of size 3 cross 3 centimeter is noted in the upper outer quadrant of right breast at 10 o'clock position.
Don't you have the picture of the patient? Don't you have the picture of the presentation? Okay, yeah.
Yes, sir. Yes, sir. Yes, sir.
Okay.
Uh,
Go on.
sir. It appears irregular in shape. Skin over the swelling had no dilated veins, no ulceration or fungation or pudgy orange. Nipple and areola, no changes comparable to opposite normal breast. No nipple retraction, no nipple discharge or fissures or cracks. Arms and thorax appear normal. Axilla appears normal. No supraclavicular fullness was noted. Sitting
Oh,
with
one
arms
minute.
raised above.
Okay. Yeah.
No lump was visible on raising hands above the head. No dimpling visible. No visible axillary swelling. Breast leaning forward position. Breasts were falling forward equally on both sides.
Okay.
Inspection is done.
Yeah,
Siddharth,
he's doing the inspection.
आप first slide पे जाएंगे. The one before. Why did you require semi-recumbent position?
Sir, recommend position palpation is felt better in semi-recumbent position, sir,
Why did you
with
require
a pillow over the
recumbent
back.
position?
Recommend and semi-recommend positions are for the palpation technique, sir.
You
Palpation,
required both positions for palpation, recumbent also, semi-recumbent also.
no, sir. If the lesion is palpable, well palpable on recommend position, that would be
Which is
appropriate.
better?
My question is, in
Recommend,
which
recommend
patients
is better.
will you do in recumbent or supine, and which patients will you do in semi-recumbent palpation? Or
Um,
you,
yes, sir. On recommend position, the lump is better palpable over the chest wall, sir. So if there is any fixity to the chest wall or the musculature, then in the recommend position or semi-recommend position would be better.
आप कौन सी पोजीशन चूज करोगे? आपने दोनों लिखा है क्योंकि मतलब sorry.
Start with semi-recommend, sir, because upper outer quadrant.
The best is semi-recommend.
ठीक है. Okay. Go to the next slide.
Why do you, what do you see when the arms are raised?
Ma'am,
What are
when the
things that
arms
you-
are yes, ma'am. When the arms are raised above the head, if there is any dimpling or retraction, it becomes more prominent. And along with that, if
When
there
do you
are
get
any
dimpling?
inframammary,
Hold on. When do you get dimpling?
when the lump infiltrates into the suspensory ligaments of Cooper, ma'am, that causes the
One is
dimpling, ma'am.
One is dimpling can be seen better. What else can be seen? Arm raised.
Inframammary folds. Inframammary fold. If there are any lesions in the inframammary fold, ma'am.
Very good. And you can see both the axilla, right?
Yes, ma'am. Yes,
Okay.
ma'am. Axilla.
Okay.
Siddharth, what's the
Fine.
difference between dimpling and puckering, or are they synonymous?
Synonymous, sir, but puckering is most commonly used when we are palpating. When on palpation it becomes more prominent, then we call it puckering. But otherwise synonymous.
No, they are not synonymous. The pathology is the same. Both are due to infiltration of Cooper's ligaments. But dimpling happens when there are one or two ligaments infiltrated, like how you get dimple on your cheeks. Puckering is when many Cooper's ligaments are infiltrated, so the skin looks wrinkled. You know, like how when you age, the skin over here gets wrinkled, that is puckering. So the pathology is the same, but the reasoning is different and the findings are different.
Okay.
Okay. You can go to the next slide. So based on your inspection, what is your impression of the lump?
Based on my inspection findings, this appears to be more of a benign swelling, sir, in the right upper quadrant of 3 cross 3 centimeter size, sir.
Wonderful. I am happy you didn't
Yes.
say malignant. What features of malignancy would label it? Means what would you look for which will tell you it's a malignant lump? Tell me 3-4 findings of inspection, which will tell you it could be malignancy.
If the nipple was at a higher position compared to the opposite breast, sir, that would be one finding. Other finding could be skin changes like ulceration or pudgy, or if there were any nipple changes with nipple discharge, active nipple discharge, or there are any lumps in the axilla, sir.
So I'll
Or
tell
the
you a simple
supraclavicular.
way. Whenever such questions are asked, you should go in a sequence or a system, like the lump going anteriorly into the skin, causing skin changes, going into the nipple areolar complex, causing nipple retraction, then going posteriorly to the chest wall, That will be demonstrated by inequality or breast not falling forward, which is your next slide. And then you look for metastasis like axilla or neck nodes. So if you give it a little system, it will be a lot easier. Then you won't have to think ye or wo, ya, because all the points are there. Okay, go to the next slide. Okay,
Do
this
we
time.
do we see for infraclavicular fullness
Yes, ma'am.
in
Infraclavicular
malignancy,
fullness.
Siddharth?
Yes, yes, sir. Yes, ma'am. Yes, ma'am.
Where do we see for where do we see for infraclavicular fullness?
Uh, Below the clavicle, ma'am. Like just below the clavicle, underneath the clavicle, ma'am.
Which groove? Any muscle?
Uh, Pectoralis pectoralis major, ma'am. The groove
Right.
of yes.
Okay, fine. Proceed.
Go to palpation.
Lump or visible. Where are we? Palpation. Okay.
Palpation, left breast appears normal on palpation. Right breast non-tender with no local rise of temperature. Single 4 × 3 centimeter size. Irregular lump palpable in upper outer quadrant of right breast at 10 o'clock position. 5 centimeter from nipple areola complex. Well-defined irregular margins. Firm in consistency. Uneven surface. Lump was fixed to the adjacent breast tissue, but lump is neither fixed to overlying skin nor underlying muscles or chest wall. Nipple
How do
areola.
we see for overlying skin?
Uh,
Fixation to the skin. How?
Ma'am, when we try to pinch the skin over the swelling, ma'am, and if it is pinchable, then we call it not fixed, ma'am.
Okay, fine. Form in consistency. How do you, why do you say it's form in consistency?
Comparing it to the consistency of my chin, ma'am, if it is similar or tip of my nose, then it is firm.
Uneven surface, right?
Yes, ma'am.
Yet you are saying it's benign, right? Form, but uneven surface, irregular margins. Okay, fine. Carry on.
Palpation of axilla. Left axilla was nominal palpation. Right axilla.
Siddharth, carry on.
Right axilla solitary 2 × 1 centimeter
Where are
non-tender
your
lymph node.
where are your
Hardened.
pictures about the palpation of axilla? Where are your pictures?
Ma'am,
How do
I
you
did not
palpate the
take.
axilla?
Ma'am,
Why?
s- from standing in front, we palpate the anterior, central, apical, and lateral group of lymph nodes, ma'am. The subscapular and supraclavicular lymph nodes
But
are
don't you
palpated
think
from
it was important to demonstrate? It was important to demonstrate, Dr. Gilda. You should have shown us, right?
yes, ma'am. I'll remember, ma'am. Next time.
Nowadays do we say anterior, central, lateral, or we say level 1, level 2, level 3? What is that? What is the new thing?
Level 1, level 2, level 3, ma'am. Nowadays, we call it level 1, depending on the
But you should have put the
lymph nodes.
pictures. You should have put the pictures, right? 2
Yes, ma'am. Yes.
centimeter, 2 centimeter into 1 centimeter, non-tender lymph node hardened concept palpable in the anterior axillary lymph node. Supraclavicular fossa is normal. How did you palpate a supraclavicular fossa?
Ma'am, we go behind the patient and with both of our hands. If we are palpating only on the right side with just one hand, ask the patient to shrug her shoulders and palpate the supraclavicular space.
Can we palpate simultaneously both the sides?
Yes, ma'am, we can because if the patient is shrugging her shoulders, bilateral can be palpated.
Bilateral you can do it? It is recommended to do it? Or is it can cause something?
Bilaterally, palpation is not recommended, ma'am, because if there is any compression of carotid,
Yeah.
it might lead to. Yes.
Your palpation is done. Anything more?
Melly too?
It may lead to syncope, ma'am. Syncope because
Bagel. It can be vagal
Vagal
stimulus.
Yeah, yeah.
Yeah, sympathy. Right.
Can you go back to your palpation slide? Lump was fixed to adjacent breast tissue. How did you check this?
With one hand, we hold the breast tissue, sir, and we try to move the lump in the breast tissue.
Which
And if
underlying
it is
muscles did you check for?
pectoralis major and serratus anterior, sir.
Pectoralis major and serratus anterior. Anything else did you check for in deeper structures? Underlying muscles and
In
chest wall. What is chest wall?
all intercostal muscles, sir, and the ribs, if they're like,
ठीक है. Go to the next slide.
How do you differentiate between fixity to the skin and puckering? Any test?
mm,
How do you differentiate between puckering and skin fixity? You have told about the pinch test. Is
yes,
it the
ma'am.
same for puckering?
Yes, ma'am. Mm, That puckering becomes more prominent on pitching around the lump, ma'am, because the invasion, like we are in sort of increasing the invasion into the Cooper segment, which leads to increase in puckering if we are pinching the.
How do you test for puckering?
Uh, uh, when we are palpating, ma'am, while palpating the lump, when we are uh, trying to palpate the lump with like pushing it and palpating, if the puckering is increasing when you
When, the,
do
when,
that.
the, when you palpate the breast, when you palpate the breast in the pendulous manner, you can see the puckering when the lump moves, right? So that's how you can see the puckering.
Yes, sir.
Okay, next.
What is the relevance of the lump being fixed to the breast?
Fixity to the breast, sir, changes our diagnosis from making it more in favor of malignancy, sir, because the
Apart from
benign
invasive ductal carcinoma, is there any other lesion which will be fixed to the breast?
phylloid tumor as well, sir.
How do you differentiate clinically whether, in your case, that it is phyllides or it is an invasive ductal carcinoma? Or in your case, based on your findings, or are both differentials open at this point? Can your case be
Differential,
phyllides tumor?
unlikely, sir, because they are in general larger lumps, sir.
Breast
With
cancer is also large only. Your patient was educated, she came early. So are both differentials open at this stage, or you will go in favor of one or the other based on your findings as of now after completion of palpation?
both are open, sir.
Is there any finding which goes against phyllides tumor?
One is larger size, sir, and second being skin changes because of larger size.
नहीं, skin changes तो phyllides में हो सकते हैं. It will not cause infiltration, but it can cause ulceration of the skin because it will cause pressure necrosis.
Why does it cause ulceration of the skin in phyllodes tumor?
Because of the pressure necrosis, because of the large size of the lump itself, it can cause pressure necrosis.
Yes.
Pressure necrosis.
Acha,
Is
just
there an infiltration of NAC of nipple areolar complex, or it's pressure necrosis in case of phyllodes tumor? And how do you differentiate? Is there any test?
Pressure necrosis, ma'am, when you can probe the skin underneath the lump, ma'am, if it is fungating.
Okay,
If you can probe it, then it is pressure necrosis.
Siddharth, I will help you with my earlier question. Do both invasive ductal carcinoma and phyllides tumor give axillary lymph node mets?
No, no, sir. Phyllodes tumor is unlikely to give any axillary lymph.
Why is that?
Because it is a sarcomatous lesion, so
Yeah.
it is in the stromal lesion. It does not
Yeah,
spread
exactly. So that's where I was getting to since the slide was open, that this is unlikely to be phyllides because it does not normally cause lymph node mets because it's like a sarcoma. And phyllides can be benign, intermediate, or malignant. So even if it is malignant, it normally causes hematogenous mets. So in my mind, it would still be invasive ductal only. Okay, you can proceed.
Case summary: lady, 39 years of age, age, non-smoker, non-alcoholic, no comorbidities, presented with painless, gradually progressing lump in outer aspect of right breast for 5 months, not associated with ulceration, nipple discharge, or swelling in contralateral breast, with no history of any malignancy in the family. On local examination, 4 cross 3 centimeter firm lump palpable in upper right quadrant of right breast with fixating to the surrounding breast tissue and no fixation to skin or underlying muscles or chest wall. A solitary hard mobile lymph node 2 cross 1 centimeter palpable in right axilla, no other features suggestive of distant metastasis. Provisional diagnosis: right breast lump, probably malignant with locoregional metastasis to axilla and no signs of distant metastasis.
What points favor your diagnosis?
The physical examination findings favored my diagnosis, especially the palpatory finding of a firm consistency, fixity to the breast tissue and axillary lymph node metastasis. So
Irregular margins.
Irregular margins.
irregular margins.
Okay. Ma'am, you want
Okay.
to ask anything?
Now we can proceed now, okay, with the investigation because it's 10 o'clock, right?
Okay.
Okay.
We'll just touch a little bit on the investigations if that's fine.
Yeah.
Okay.
Dr. Gilda, proceed with the investigation. What would you like to do on this patient?
The triple assessment, sir, of any breast lump, sir. I would go with mammography, ma'am. Because she's a younger patient and denser breast,
What is
we
triple
might use
assessment?
ultrasound.
Sorry,
Triple
I'm
assessment,
interrupting you. Dr. Siddharth, what is triple assessment?
clinical examination, ma'am, along with imaging, mammography, and tissue diagnosis with through cut
Okay, fine. What have you done on the
code
patient?
biopsy. Sorry, ma'am.
Proceed with the investigation.
What have you done in this
Show the
patient?
investigation.
Ma'am is asking.
That's it, ma'am. Actually, the patient had just come and we could not follow her up further.
But why did you choose such a case, Dr. Siddharth? This is an incomplete examination, right? Anyway, what would you like to do on this patient?
Ma'am,
Mammography?
I would like mammography, ma'am, with the support of ultrasonography, if possible, and if needed, because it is a denser breast tissue in 39 years of age, and followed by ultrasound guided
1 minute.
biopsy.
You're
If
doing
suggested of it.
sonography because it's a dense breast, right?
Yes, ma'am. Ultrasound,
What
if
does
it is dense
mammography
breast, ma'am.
show? What are you expecting to see in mammography?
Mammography will suggest a BIRAT score for the patient, ma'am, which will help us in going for core cut if needed, ma'am.
What are the features of a malignant tumor on mammography?
Okay, ma'am. If the lesion is taller than wider, if the lesion has any microcalcification associated with it, and vascularity, which may be seen on ultrasonography or Doppler, these are three predominant features, ma'am.
What is a better test for lymph node, a sonography or a mammography? Metastatic lymph node.
Ma'am, ultrasonography, ma'am, because the like the view of mammography is will not be helpful in viewing the axilla.
Okay, what does a lymph node look like on a sonography, a metastatic lymph node?
The metastatic lymph node might have loss of architecture with halo sign, ma'am, with central necrosis of the lymph node, along with increased vascularity, with multiple of lymph nodes may be present.
What is a normal shape? What is a normal shape of a lymph node, and how does it differ in case of malignancy?
Ma'am, it is normally kidney shaped, but because of a central necrosis, it may undergo changes into a spherical shape, ma'am.
Okay, fine. Sir, would you like to ask? Dr. Nasta, would you like to ask something?
Yeah. Don't you think you should be doing an MRI in this patient? MRI of the
MRI,
breast. When do you think about doing an MRI of the breast?
MRI is indicated if there are any familial risk factors associated, or if there are any multicentricity, or if we are suspecting it. we can, if mammography and ultrasonography are not conclusive, then we might go for MRI because of high suspicion, sir. Because
Have you
these are
heard of
dense
the
fields.
word occult? Occult?
Yes, ma'am.
Occult.
Yes, ma'am. If there is no palpable lump, but the axillary lymph nodes are palpable, then we would call it occult primary with axillary lymph node metastasis.
Yeah, are these satellite lesions, are they in the breast tissue or somewhere else?
Sir, ma'am, satellite nodules are the skin changes, ma'am, present over the skin.
Yeah, very good.
Uh,
Yeah.
yes, ma'am.
You would like to do FNAC or core biopsy? Or first you
Core
will do
biopsy, sir.
FNAC, then you will do core biopsy. What is the reason?
Core biopsy, sir, because core biopsy helps us distinguish between the invasive component, if it is an invasive malignancy, along with the molecular subtypes,
ये in
which
situ तो हो
which
ही
is
नहीं
not.
सकता. It's such a big lump. I don't think it can be in
Yes.
situ lesion. So that point does not hold good. Immunohistochemistry, do you want to know preoperatively?
Yes, sir. Immunohistochemistry preoperatively,
Why?
because it will aid us.
If you do an mastectomy anyways, you'll get the IHC on the specimen.
Yes, sir. IHC on the specimen, yes, sir. But if it is ERPR positive upfront surgery for a 4 cross 3 centimeter is fine. But if it is a triple negative breast cancer or HER2 new positive, then if it is more than T1B, then we would want to go for new adjuvant initially, sir.
T1B, your lesion is T1B only, na? Your lesion is
No,
T2. It is T2.
T2. Yes, sir. Yes, sir. So if
So
it was molecular, if it was TNBC or HER2 new positive, then we would go for neoadjuvant chemotherapy first, sir.
okay, simplest thing is core biopsy, the chances of getting a positive diagnosis are much more than FNAC. It has a much more sensitivity and specificity. Then the other point that you are saying are fine. Okay, chalo, let's assume it is a invasive ductal carcinoma. Your triple assessment is done. What will you do next? You did your triple assessment, you got a diagnosis. It is an invasive ductal carcinoma, 4 cross 3 centimeters with ipsilateral axillary lymph node. अब क्या करोगे?
Sir, we'll
Would you
counsel
like
the
to
patient.
मेटास्टेटिक वर्कअप करना है क्या कुछ इसका? करोगे क्या?
Ma'am, the guidelines suggest that without any clinical history suspicion, there is no need to go for any
मेटास्टेटिक वर्कअप.
metastatic. Yes, ma'am. Those are the guidelines.
Supposing when you have to do a metastatic, when it is not in this case, when it is a advanced malignancy, what would you like to do? PET CT? Or
No indication for PET CT again, ma'am. CCT abdomen along with HRCT thorax.
thorax?
But yes, ma'am. HRCT thorax along with
Okay.
along with
Why
chest.
not PET CT? Okay, you are right. Why not PET CT?
Ma'am, we can have the reason that PET CT is not still in the guidelines because of lack of evidence. Plus, there is increased false positive rate.
Right, where? Liver and brain.
Lungs, ma'am, and more in lungs, and brain also, but brain is not seen in FTG PET CT per se.
When do you do a bone scan? Which blood biochemistry you see and you go ahead with the blood scan, bone scan?
Blood investigation pointing to making us want to do a bone scan, ma'am.
Yeah.
I don't know, sir. I don't know, ma'am. Sorry.
It's a basic, Dr. Nasta, isn't it?
It's okay. Like
No,
any
no,
marker of
ऐसा ऐसा करो.
metastasis
चलो,
causing
you can
bone
find out.
erosion.
Fine. आगे, what did Sir say? Sir is asking you the management now.
Ma'am, I think we'll stop here. Is it fine?
Sir, management खत्म कर लेते हैं ना इसका क्या? What does he want to do?
What's your plan? You've done the workup. You've done metastatic workup also. It is T2N1. What will you do next?
Counsel the patient, sir. We can opt for BCS in this case with axillary dissection if the patient wants BCS particularly, sir. Or else we can go for MRM, sir.
What are the components of BCS?
BCS is lumpectomy, sir, along with mm, radiotherapy, sir. There are two components for breast conservation treatment, sir.
So radiotherapy is compulsory or it is optional?
Compulsory, sir,
So
for any
then the
breast
correct name
conservation
of the
management.
treatment should be BCT, not BCS. It's not
BCT,
surgery,
sir.
just one of the parts. What about the axilla? Do you want to do axillary clearance or you want to do something else?
Sir, clinically palpable lymph nodes, I would go for axillary dissection directly
If it
rather
was an
than
N0 case, then what would you do?
SLNV, sir, sentinel lymph node web,
How
because
do you
of
do
a
it?
large latent T2.
Something else. How do you do it? How do
Sentinel
you do
lymph
it?
node biopsy. The sentinel lymph node biopsy can be done using methylene blue intraoperatively on the operating table.
Where do you inject
By
it? Where do you inject it?
we inject it around the lump, ma'am, and give a massage for 5 to 10 minutes, and then check for the lymph node during axillary dissection. Consent it, or we can go
What,
for even radioactive.
what will you do when you find the sentinel lymph node?
Send the sentinel lymph node for frozen biopsy, sir.
And
And if it comes out to be positive, then we go for axillary dissection. If it comes out negative, then we stop right there.
TK, in which patients will you not offer breast conservation even if she is an early breast cancer?
If there are any contraindications for radiotherapy, sir, that becomes one component, or if the size of the lesion is more than 5 centimeter, or the lesion is more than N1.
What are the contraindications for radiotherapy?
Absolute contraindications are pregnancy and homologous mutations of ATM, ataxia telangiectasia
ये
mutations,
तो कोई check नहीं
or
करता है.
related
Tell me things which
relative
are common. Don't tell me theory.
relative
Pregnancy is fine.
contraindications.
Any other
Yes, sir.
contraindication?
Relative contraindications are connective tissue disorders like SLE or scleroderma. So,
Why?
it makes radio sensitive, so it makes the
ठीक है,
it
no
makes
problem. Any other contraindication to radiotherapy apart from the ones that you said, pregnancy and connective tissue disorders? Which is very
the recurrence
important.
of
Very
recurrence of
important.
the disease. The recurrence of the disease more than 5 centimeter.
Recurrence में तो आप BCT नहीं करोगे. I am saying a
BCT नहीं
contraindication to radiotherapy. Very important contraindication. If she has history of prior chest radiation.
Prior chest radiation, yes.
ठीक है, fine. What are the components of MRM? Modified radical mastectomy.
Modified radical mastectomy. The components include, sir, removal of the breast along with the nipple areola complex, along with the level 1 and 2 lymph nodes, sir.
Anything else that is removed in MRM apart from breast, nipple, areola complex, and level 1, level 2? Anything else?
The pectoralis minor may be divided, sir, but not removed, sir.
No, which
in
is
MRM.
compulsorily removed as a part of
Fascia.
pectoral fascia.
Fascia.
Pectoral fascia.
Yes,
What is the
yes,
difference
yes.
between MRM and radical mastectomy, the original?
The pectoralis muscles were also removed in the radical mastectomy along with level 3 lymph nodes also.
Okay. Basically, in radical, he removed the pec major, sometimes even the ribs.
Did you, Dr. Gilda, did you ask for the cup size of the patient? And why? Why is it important? Did you ask about the cup size of the patient and why is it important?
Expectation of the patient, ma'am, if the patient wants to go for any oncoplasty technique, oncoplasty surgery.
Recon, yeah. Recon. Yeah, right.
Reconstruction.
Okay. Sir, anything else? Dr. Nasta, anything else you want to ask? I think we are...
I'm good, I think, ma'am.
Okay, one last question, very simple question. Dr. Siddharth, let me know what another investigation would you like to do in this patient apart from blood biochemistry, mammography, or metastatic workup, which is another one important investigation in case you have to give chemotherapy to the patient? And which chemotherapy?
2D echo, ma'am, if the patient is supposed to go for doxo
Very
anthracycline
good.
therapy.
Yeah, very good. Fine, that's it. Dr. Nasta, your call, please.
I'm quite happy, Siddharth. You've done a great job.
Yeah, excellent job. So that
It's a
I
great
wish you
job.
would have done shown us the mammography and you would have had the patient for further investigation.
No, but
But excellent job.
Dr.
Good, very good.
Siddharth, I'm very happy, and I am quite a tough examiner. Ma'am is also quite a tough examiner, and I think you did quite well. So I think if you continue
Yeah,
like this, I think your
congratulations.
exams will go quite nicely.
You're in which year, Dr. Gilda?
Just entered my third year, ma'am.
Okay, very well done. Excellent.
Thank you.
All the best to you.
Thank you,
Thank you,
madam.
ma'am. Thank you.
And
Sir.
regards
sir.
to thank you, Dr. Nasta. Nice to share the session with you.
My pleasure, ma'am. Happy to see you.
Can we call it
Super sir,
a day?
Super sir, any closing comments you
Bye.
want to say?
Priya, are you there? Priya?
I think he did very well. I have no other comments. This is very nicely done. I enjoyed it.
Right. Okay, then we close up for today. Thank you for spending your weekday evening with us. Thank you, madam. Thank you, sir.
Thank you.
Thank you so
Yeah.
much.
Thank you, ma'am.
Thank you.
Thank you, sir.
All the best, Dr. Gilda, and regards, Dr. Nasta. Bye.